evaluation of PE. And a lot of times patients who are critically ill, they're at higher risk. They can have sudden hemodynamic changes, and that's always on our minds, right? Um, Now, echo is difficult when it comes to RV assessment. And we'll talk a little bit about some of the challenges for RV assessment with echo. It's because it is a very thin-walled structure. It has a very complex contraction mechanism, and its location is directly behind the sternum, which can make imaging or thorough imaging really challenging. And this is sort of a classic image in the echo literature, which shows that depending on the angle of that you're acquiring your image, a very normal RV can look really big, right? So depending on how you're angulating your probe, it can make the RV look really big when your RV may not be dilated. And so it's very important that you don't just use one image or one view, that you do utilize all the different views that you have in your arsenal. And that's why cardiologists have really resisted using cutoffs for numeric cutoffs for dilatation. And what we generally say is we look at the apical four-chamber view in addition to other views. And we say if the RV is smaller than the LV, that's normal, which is the scenario on your left over here. If the RV is the same size as the LV, it might be dilated, and if it's larger than the LV, then that's marked dilatation, which is what we're seeing here on the right side. Now, RV contraction and assessing RV systolic function is difficult, and for the exact same reasons that I discussed about why looking at RV size is difficult. One of the ways in which we use echo, and in particular using M mode to look at how tissue is moving throughout the cardiac cycle, is to calculate something called TAPSE. So that stands for tricuspid annular plane systolic excursion. And basically what we're doing here is we are putting a pulse wave, right? We're putting a pulse wave at the tissue at the annulus of the tricuspid valve. But this is in a modality of echo called M mode, which has the highest temporal resolution. And basically what it does is it just shows us this 2D image of how tissue is moving temporally. So you have, your EKG at the bottom over here, and what you are looking at is every echogenic or echolucent structure along this green line. So you're starting off at the apex, then you have part of that mid RV cavity, and here is where you're touching that tricuspid annular plane. And if the difference between systole in terms of its longitudinal motion and diastole is more than 17, it's considered normal. And if it's less than 17, it's considered reduced. And those patients tend to have a worse prognosis. Now, this is a correlation, right? So there is, TAPSE is something that's been used in the literature, particularly with pulmonary hypertension patients. In patients with acute PE, they can really move that lateral annulus up and down very vigorously. But when you actually look at the area change of the RV, it may not be it may not be normal. So TAPSE is used. It's easy to use, but it does have its it does have its limitations. All right, so let's take a look at a patient where there looks like there might be something going on with the RV. We have a reminder here. This is your parasternal long axis view. So this is your RV over here. Take a look at the LV, and in comparison to the prior echoes that we just took a look at, this RV is taking a lot of this space, right? It's, if not the same, more than the LV. And this is your short axis view. And what I want you to note, I'm going to let this play for a little bit, is that there is D'ing of the septum, right? So that septum is not nice and round throughout the cardiac cycle. In systole and diastole, you're seeing flattening, and that tends to suggest that there is both pressure and volume overload. And this is our apical four-chamber view. And as a reminder, this is your LV. This is your RV. It's huge, right? It's much bigger than the LV. It's actually so dilated that it looks like there's malcoaptation of the tricuspid valve, and the right atrium is really big. Now, if we take a look at TAPSE here, this TAPSE is 13 millimeters, which I said less than 17 is abnormal. So again, this is has both by TAPSE and visual estimation, we can see that the RV is not moving very well. And just to review what we had talked about, when you look at the IVC, if it's dilated and it's not collapsing, that is giving you a right atrial pressure of around 15. So we see that the right-sided pressures are elevated. Now, is this acute or chronic? And that ends up coming up a lot. You know, when you have a lot of remodeling, like the right atrium is as big as it is, it's really difficult to know. And so, you know, a lot of times we get called for PE cases, and I want everyone to just be aware, you know, echo is not a great modality for diagnosis of PE. So, you know, you can have a PE and have a completely normal right side. The PA pressures may be slightly elevated, but it's not good for diagnosis. It does tell you something about prognosis, and it also can give you an idea if there is a massive PE. We tend to see very specific findings on echo. So this is an illustration of McConnell sign. And I think we've all kind of heard about it, but this is a great image I found that that shows you, you know, exactly what this looks like. So just to remind you, this is the LV over here. This is the RV, big and dilated. The right atrium is dilated too. So you think, okay, is this a chronic problem or is this an acute problem? Now, McConnell sign is where your mid and basal segments are akinetic or hypokinetic, but the apex is really contracting, really contracting. It's hypercontractile, and you can see that over here. And this has a specificity of around 97% of being associated in the setting of a PE being associated with a PE. Now, not all PEs are going to have McConnell sign. It has a low sensitivity, around 22%, but if you see it, you should think PE. All right. So as a reminder, RV geometry makes it difficult to assess RV size by echo, so you want to make sure to use multiple views. And McConnell sign is highly specific, but not very sensitive. So if you see it, you want to think, you know, is this an acute PE? But not all PEs are going to have McConnell sign. So in terms of what we discussed so far, the take-home points I hope we're able to take from this talk is, you know, your ejection fraction is not cardiac output or volume status. EF is dependent on loading conditions. The cardiac output, though, can be calculated using Doppler data, and you want to consider E to E prime calculations for estimation of left atrial pressure. In terms of pericardial effusions, the size itself does not reflect tamponade. Echo parameters can help you determine whether, you know, this is clinical tamponade by seeing whether the intrapericardial pressures are higher than the intracardiac pressures by looking for things like chamber collapse and echocardiographic pulse paradoxes. And RV geometry does make RV assessment difficult. You want to make sure that you're looking at multiple views, but also McConnell sign is highly specific for acute PE. Any questions?
Thank you so much, Yasmin. I just want to